पास आयुष्मान कार्ड है, वो रची है, उन्होंने बोला ठीक है पलासिया के ग्रुप में हमारे मेडिकल हॉस्पिटल में एडमिट हो जाइए, इनका ऑपरेशन हम वहाँ कर दें। ये चैलेंजिंग जो ऑपरेशन है मैं इसको करूँगा, आप चिंता मत कीजिए। और विपुल सर पे क्या पूरा बड़ौदा ही भरोसा करता है, पूरा भरोसा करता है, इसलिए हम उस भरोसे की तरफ गए और निश्चित हो गए इस पेशेंट को हम विपुल सर के हाथों में सौंपने के बाद सर 15 तारीख को हम एडमिट हुए।
Recently we did one case in which the aorta near the root ruptured into a chamber. It is called sinus of Vaghela aneurysm, which is ruptured. And we are going to talk about that case, how it was presented and what we did. Imagine any patient who is adult, 20 to 40 years of age, to a young adult, without any problem, no symptoms, and suddenly that patient collapsed and had a dyspnea at rest without any prior warning or any preparation. Within hours, patient is in heart failure. Before they know anything, they are on ventilator. Usually this is because of something like aortic aneurysm which is ruptured or RSOV or something intraventricular septal rupture. These are very catastrophic events, and if not dealt with early diagnosis and early action, these patients are succumbing. Basically they are on a very thin thread of life. If it breaks, even in the hospital, nobody can do anything. So the idea is to earliest you need to identify. So this was the CT aortogram of the patient in which one of the sinus had an aneurysm and which has opened into one of the chambers. You can see this. This one. So I will take you through this case which we recently did it just 14-15 days back. So how many of you has already seen any ruptured sinus of ulcer in your entire practice?
They heard of it.
Heard of it. So we theoretically see whenever we are reading our book Golwala or P.J. Mehta, we see the continuous murmur, one of the differential diagnoses is the rupture of sinus. In my practice, I have seen 38 cases, 4 in Bankers and rest all in Amrita Institute of Medical Sciences. I have seen rupture in all chambers, including interventricular septum. That was a case here in Bankers. And unruptured also I have seen 3 to 4. So it is extremely rare. If somebody has seen in their life, it is as good as you are a seasoned a doctor in the field of cardiology. So that is the reason that when this patient came, I told all my DNB students that please go and have a look of this patient. So sinus of Vaghela, basically it's an aneurysm which is arising from the sinuses of aorta. Either it is unruptured or it is ruptured. The presentation is usually ruptured. Unruptured, usually it is identified only on doing a TE or on a CT scan, CT aortography, not saying simple CT scan, and which is very, very rare. You can say I have seen only few cases of unruptured, and because they don't have any symptoms unless it is too big. So once it is ruptured, they will present very fast to the hospital, and if they survive and if you diagnose early and operate early, they give very good long-term result. So we usually double patch bicameral repair. I am coming to that in the later part of the presentation. But before we go, so what is ruptured sinus of Vaghela? Basically, it is a rare congenital anomaly where aortic sinus rupture into cardiac chamber, usually right atrium or right ventricle or percent. How common? It is extremely rare, 0.1 to 0.5% of the all congenital heart disease. More common in Asian population, and the age usually between 20 to 40. Particularly young male, 3 is to 3 or 4 is to 1 ratio. The more male are more predominant. What is the cause? There are two basic causes. One is congenital, which is most common due to weakness at the junction of aortic media or annulus fibrosis, or acquired because of the trauma or infective endocarditis or aortic root disease, or post-surgical, like putting a angiogram catheter. If the Judkins right, it is hitting in a weak area, okay, it can create aneurysm formation. So whenever you are doing any intervention near the root, okay, it can happen. I have not seen even single acquired case, but congenital one, I said a lot of cases I have seen and I have done it.
So the first statement है ना, तो say कि left to right and right atrium और उत्तर right है. So because ये aortic sinus है, pressure तो right to left बता रहा हूँ, left to right बता.
Left to right. Left means left system, coronary, left heart system, where oxygenated blood is there and the pressure is high, 120 by 80.
तो उत्तर तो right atrium में था.
Right atrium में था, right atrium में pressure 5. Right atrial pressure and right ventricular pressures are almost 1/3 of system. Right ventricle. So જ્યારે પણ તમારો shunt થાય, it is left to right.
બેઝિકલી રપ્ચર એટલે ખાલી કાણું પડ્યું પણ લેફ્ટ સાઈડ નો પ્રેશર વધારે એટલે કાણું પડ્યા પછી શન્ટ તો લેફ્ટ ટુ રાઈટ માં ડેવલપ થાય
લેફ્ટ માં રાઈટ માં
I'm coming to that. Video will understand everything. So which is the most common site? Okay, so if you see the anatomy of the root, this is the left coronary sinus, this is the non-coronary sinus and right coronary sinus. Usually the aneurysm, weakest portion of these three is right, then the non-coronary, and the least one is the left coronary. So right coronary sinus, usually there is aneurysm, and usually it is open into right coronary. Right coronary, almost 70 to 80% cases you will see in the right coronary. Non-coronary 10 to 30%, and very rarely you will get less than 5% from the left coronary. Where is the commonest site of rupture? Then site of rupture means in which chamber it is opening. Okay, so usually it is in right ventricle, which is most common because the majority is from RCC. The second most common is the right atrium, but we have seen cases in the left ventricle also, left atrium also, and the free also. So these are the where it can enlarge because these are the proximity or adjoining chamber next to the sinuses. So what is the clinical presentation of rupture? Usually it is acute onset pain, dyspnea, and when you auscultate there is a continuous machinery murmur. It is a sudden onset. Usually patient will have a palpitation. Patient will have the right-sided heart failure signs, and most of the patients' initial presentation is in cardiogenic shock. It again depends on how big is the rupture. So this picture is very nicely depicted where the aneurysm opens. This is the right coronary sinus which is opening into LV. Then in the RV, you can see non-coronary sinus opening into left atrium. Then the non-coronary sinus opening into right atrium. Similarly, right coronary sinus can open into left atrium, and similarly, right coronary sinus can open into right atrium. So these are the different ways, and beautifully describe.
right opening into left ventricle would be the very rarest.
Pardon? Right.
Right sinus opening into left ventricle must be very rarest.
Very rare, very rare. I have seen only one case here only in Bangalore, and patient is already there. So what are the associated anomalies? So most of the cases are without any associated anomalies. One is a congenital heart disease, so you can expect around 30 to 60% cases VSDs or aortic regurgitation because of it is very next to the aortic annulus. Other conotruncal anomalies like tetralogy or tricuspid atresia, pulmonary atresia, these type of conotruncal defect or fusion defects or abnormal neural crest migration defects can present along with these type of RSO. So before we go inside this one, we need to identify any other associated anomalies are there or not. Otherwise, on table there will be big problem. Now, how to diagnose these type of anomalies? So most important thing is clinical examination. I am coming to the next 2 or 3 slides on clinical examination. And the TE and the TEE both are very important. TE is very important because it can give you good picture of aortic root, where it is opening, where exactly what is the size, any other associated anomalies, and how much is the shunt, that also you can identify with the TE. Another is CT and MRI. We prefer CT because it gives a good anatomical exact dimensions, and rarely we require a CAT study or angiography. We have also done in this patient, not for this one, but patient was 42-year-old. That's the reason that we did a coronary angiogram just to find out whether is there any coronary blocks or not.
42.
42, yes. So what are the differential diagnoses for this? Basically all differential diagnoses of continuous murmur. Okay, either a PDA or continuous coronary cameral fistulas, or coronary cameral fistulas means coronary is opening into one of the chambers of heart, either usually right side heart or right atrium. VSD with AR or infective endocarditis with fistula, these are the cause of differential diagnosis for this. If you don't do anything in this patient, what will happen? So rapid progression to congestive heart failure. Most of the time it is there is a mortality. If the patient stabilizes and still if you don't do anything, there is a high risk of death within 1 or 2 years of rupture. Again, it depends on the size of the defect. So what are the surgical indications? So all rupture RSOV needs urgent surgical repair. No other option. Even unruptured but enlarging, on every 1 year CT scan, if it is enlarging in the size or it is associated with other lesion like aortic regurgitation or any VSD or any other conotruncal anomalies, in that case, even if it is not ruptured, we need to address both this associated lesion as well as the unruptured sinus. What are the surgical technique? Usually PTFE or Dacron patch is required to repair this defect, either from one side or both the side. If you close from one side, one chamber, it is called unicameral repair. If you do it from both the sides, it is called bicameral repair. So the gold standard is bicameral repair because it reduces the chances of resurgery. Repair of associated VSD or valve replacement if it is needed. In that case, it needs to be done. And another thing is cardiopulmonary bypass will require in all the patients. Heart required to be arrested because you are opening the heart chambers. What are the outcome of surgery? Excellent prognosis if operated early. If you operate when the liver dysfunction occurs, renal dysfunction occurs, and the shunt is small, and there is a huge left to right shunt, and heart is balloon, in that case, and with associated anomalies like aortic regurgitation or infective endocarditis, in that case, the prognosis is not that good, but if you operate early, then the prognosis is very good. Operative mortality in most of the centers in large cities it is less than 5%, 2 to 5% in isolated RSOV. When it is combined with other procedures like valve replacement, infective endocarditis, then the operative mortality is around 9 to 8%. Long-term survival, once the patient is operated and discharged home, usually 10 years, there is no issue in isolated RSOP, almost 99%, but associated with any other valve replacement or congenital anomaly, and the 10-year survival is greater than 90%. So there are excellent results of surgery. It should be referred as early as possible. Patient do ask whether it can be closed with the transcatheter device closer. Yes, in selected cases with suitable anatomy or no associated lesions like aortic regurgitation or any congenital anomalies, we can devise with the occluder, but surgery remains the gold standard. Against the surgery, all other procedures are compared. What should be the referring physician should know? Always suspect RSOV in young patient with new continuous murmur with acute dyspnea. Early referral for echo and surgical opinion saves life. Prognosis is excellent with timely surgery.
Is there any difference between pregnant and non-pregnant women?
Pregnant and non-pregnant? Yes, definitely, sir, because it is a hyperdynamic circulation. When there is any left to right shunt is there with the hyperdynamic circulation, the shunt will be more. The patient will deteriorate very rapidly. Most of the time, the pregnancy will not last. But such situation I have not faced, and it is not there in the literature.
Because the dissection is very common.
Dissection is very common, extremely common in a pregnancy along with this. So basically we are dealing with the continuous murmur. There are two situations of acute continuous murmur or chronic continuous murmur. So acute, there is a PDA, but usually acute in the, just after the newborn, just after the born. The newborn or infant will have a continuous murmur, and it is usually because of the PDA, or in an adult, either it is related to rupture sinus of Vaghela or iatrogenic AV fistulas. Now, iatrogenic AV fistulas, either you are doing some coronary procedure or some vascular procedure, and the wire is hitting from the lumen into the venous side or any chamber. It causes the iatrogenic AV fistulas, and that gives a very high volume acute continuous murmur. The onset is usually sudden. Murmur timing and character, it is a machinery murmur which is very harsh and it is very high flow. Murmur site in a PDA, it is in a light left upper border, second intercostal space here. Okay, and rupture sinus of Vaghela, it is in right sternal border, and the murmur goes towards radiate to apex. And AV fistula, it depends on the site of AV fistula, and it is a localized. It does not radiate, it is localized. Whereas associated features like heart failure, tachypnea, pulmonary edema, hypotension, these are there in most of the such cases. Pulse and BP findings, bounding pulse, if it is PDA, may have hypotension in rupture. So these are the most important. The acute continuous murmur, most of the time in adult, it is related to rupture of sinus of Vaghela. Again, these are the conditions in which there is a continuous murmur. I am not going into detail, but in the case of RSOV, it is acute in onset, sudden rupture, pulmonary edema, heart failure, chronic cases, which is very, very rare, but if it is treated, untreated, may develop chronic heart failure. So whatever we have discussed, it is there here, but one more point I wanted to mention, the device closure was first done by Cullen in 1994, and the patient successfully went home and with good long-term result, but that rupture was only 2 mm in size. There is a classification. This is for DNB student. In an exam, they ask what is the name of the classification. Sakakibara and Kono. This is very old classification. Recently, one modified Sakakibara classification. It is based on from which sinuses it is arise and where it is open. So type 1 is originating from the left part of right coronary sinus. Left part is somewhere here. This is the left part. This is the right part and then the central part. left part protruding into conus of right ventricle. Now what is conus? Conus is right ventricular outflow tract, somewhere near the pulmonary artery. Whereas 2 is originated from the central part of the right coronary sinus, protruding into right ventricle, somewhere in the middle. Here there will be crista ventricularis. There is a muscle which goes in the conus and the body of the right ventricle. So this crista ventricularis, that part it opens. 3A and B. So this one is originating in the posterior part of the right coronary sinus. It usually opens at the membranous septum. Membranous septum is where the AV node lies. So most of the patient with 3, you can diagnose easily on ECG whether the patient is having a complete heart block or not. If complete heart block is not there in RSOB, that means 3A, B is out. Originating from the posterior part of the right coronary sinus here, and it is opening into right atrium near the commissure of the septal and anterior leaflet. There are two commissures, but septal and anterior leaflet of tricuspid valve near to junction, if it is ruptured, and it is called 3A. Whereas originating from the right part of coronary sinus, non-coronary sinus, into opening into right atrium, it is 4. But here in modified, they have mentioned other chambers as well as the pre-rupture. There are many other ways you can classify. These are the different classifications based on the origin of the sinuses, where it is ruptured in one chamber or bicameral or in complex, or based on etiology like congenital or acquired, or based on any hemodynamic impact, acute or chronic ruptures. This is I have made my self-diagram to make you understand that where usually continuous murmur will be. So if it is a PDA, it is between the aorta and the pulmonary artery. So it is in the left just below the clavicle. There will be AP window, means it's a congenital anomaly, usually less than 5 years or 10 years of age. Patient rapidly, there is a window between the aorta and the pulmonary artery, main pulmonary, it is called that. So it is in the left parasternal region. Then if there is any coronary artery to venous fistula, then there will be localized murmur here. Or if there is a rupture of sinus of Valsalva into right atrium or right ventricle, which is the most common, you can hear it the left side, right side, even apex. Intercostal or pulmonary AV fistula, usually you will hear on the lateral side of the chest. So these are the continuous murmur usually we come across. This is for DMB students. In exam they ask such question. Now if you see continuous murmurs, there are a lot of ways you can identify. Suppose in mitral position continuous murmur, either it is a coronary fistula, mammary supple or MAPCAS. Now what is MAPCAS? Whenever there is a pulmonary atresia or critical pulmonary stenosis, congenital one, there is a multiple aorta, from the descending aorta to pulmonary lungs, there will be a collateral circulation. Because there is no antegrade flow in the pulmonary circuit, the lung receives blood from the aorta, and that creates a multiple MAPCAS. And when you have a MAPCAS, before doing surgery for this congenital heart, you need to either coil that MAPCAS, otherwise you will have a flooded lung once you do a surgery. Continuous murmur at back, behind. It is because of either a MAPCAS or pulmonary artery stenosis. Now when I say pulmonary artery stenosis, it is not main pulmonary artery, branch pulmonary arteries. Left and right, the branch coronary near the hilum. Because most of the cases of pulmonary atresia and tetralogy, they have branch pulmonary artery stenosis, and that's the reason that all tetralogy or pulmonary atresia, when you operate, you need to do CT pulmonary angiography to find out branch pulmonary artery stenosis. Again, continuous murmur at tricuspid area, coronary fistula, mammary supple. Now, what is mammary supple? Pregnancy. Whenever in pregnancy related and lactation induced enlargement of the vasculature, there is a memory suffer. Then in aortic area, either modified BT shunt, coronary fistulas and MAPCAS. Now what is BT shunt? Whenever there is a pulmonary artery stenosis, congenital one or pulmonary atresia, there is no blood going into pulmonary artery. So surgeon, when patient is very small infant, they create subclavian to pulmonary artery shunt. That is called BT shunt. And because of that, it is just like creating one more PDA. Okay. So patient will enlarge in size over a period of time, 2 to 3 years will get to enlarge the pulmonary artery, and later on we can do complete intracardiac repair. Then the venous humps usually below the clavicles, and these are the continuous murmur heard in the pulmonary area like PDA, MAPCAS, coarctation, pulmonary artery stenosis, coronary fistulas, modified BT shunt, and to and fro murmur. This is again very important. To and fro means there is a sound S1, S2 heard in between. So continuous murmur from S1 to again S1 is a continuous flow. Usually it is a crescendo and decrescendo. Whereas in to and fro there is a distinct S2 will heard in between. So to and fro murmur, it is also a continuous murmur, but there are two types. The lower one is usually because of aortic stenosis and AR associated, or PS with PR associated. So there are only two conditions you will get to and fro murmur. If I am wrong, please physician, senior physician, please, because I am not good in clinical. So our patient was 42 years, 50 kg weight. Patient presented with the acute onset respiratory distress in heart failure. Patient had anemia and fetal edema, reduced air entry to right lower zone, elevated JVP with systolic pulmonary pulses visible in the neck. This patient was from the Bharuch. Some physician has diagnosed some murmur and they referred to a local place where echo done. They have not mentioned any, but it was a transthoracic portable echo. So we can understand that it can be missed. So because the patient was having a severe respiratory distress, they immediately sent the patient to our hospital. We did initially TE and we found that there is a aneurysm and there is a leakage into right atrium. So you can see that there is a right coronary sinus which is leaking into right atrium. You can see that this is a coronary, aortic root, and this is a non-coronary sinus. There is a shunt into the right atrium. This is the 3D, same of this, the 3D image. You can see there is a shunt here. This one is the aneurysm. You can see very nicely. You can see the small, this is the windshock deformity of ruptured sinus of Aorta. So on opening, I have seen this before going on. Right atrium and right ventricle is little bit dilated, and after opening, this is the non-coronary sinus. There is a huge, almost 1 centimeter. This is the aortic valve. This is a non-coronary sinus, and this is the right atrium, and this is the pulmonary valve, and this is the windshock deformity which is opening into right atrium. You can see that it's huge. So what we did, we went on pump, heart-lung machine, opened the both the aorta. Aorta just above the sinotubular junction. First we close from the aorta with the PTFE patch, which is we have used continuous sutures. And once we pass this, we check the aortic valve, whether is there any regurgitation is there or not.
फालतू हो गया, ऐसा देखा नहीं होगा। मतलब फुसफुस जैसा कुछ चेक तो होती है।
So this is the, this we have checked the valve, it is not leaking. And once this is the wind shock which we have excised and again repaired from right atrium 2 with the patch. Again we have used PTFE to both the sides. This is for bicameral repair. 2 more seconds. So PTFE patch we will use. We have to excise this wind shock and we have to check underneath valve, nearby valve. Is there any leakage is there or not? If it is leaking, so we have checked the packaging valve. There is no leakage. So yes, if you compare device, when to do device and when not to do surgery, so most of the cases device is not possible because it is very close to aortic valve annulus. Another thing is usually in that wind shock there is many patients you will find infective endocarditis, vegetation. So if there is a vegetation, patient is in septicemia, if you put a device there, any foreign body, without removing that, the chance of getting infection on the device is very high. But yes, device closure is possible, it is a minimal invasive. Very small or moderate isolated RSOV, you can devise that. It reduces the hospital stay, faster recovery. Recurrence is possible if the anatomy is unsuitable and cardiologist has done that. Device embolization, AR and leak into through the device is possible. Overall success is 85 to 90% in selected patients. Whereas surgery is always a gold standard, but it has got its own complications like bleeding, arrhythmias and infection. Device closure advantages are minimal invasive, shorter hospital stay, less pain, cosmetically very good for selected patient. Whereas disadvantage and limitations are not suitable for large rupture, multiple sinus rupture, difficult if associated with aortic regurgitation, VSD or any structural heart disease. And long-term data is not available in any literature. And it requires fluoroscopy and contrast. And another important thing is, this cannot be done by any regular cardiologist. It is to be done by a structural heart interventional cardiologist. So very few in India they are doing exclusively this work, the structural heart. Those who are doing TAVI, TMVR, these people usually do this device closure. Surgery is gold standard as I said, but it requires a cardiopulmonary bypass, scar, it requires a longer hospital stay and recovery, and it is invasive. Higher perioperative risk in elderly and comorbid patients. Key takeaways for all of us is early recognition, high index of suspicion. Auscultation is mandatory, still there is a role of stethoscope. Immediate reference, avoid delay, outcome depends on speed. We operated within 3 days of diagnosing. So this is the final word. The patient who comes gasping, walk within just 7 days, that is the miracle of time research. Broader message is, as a doctor, our role is not only to treat common condition, but to stay alert for a rare, life-threatening one, because in that one case, knowledge can mean the difference between a tragedy and trauma. Where the aorta breaks, refer early, with timely recognition, surgery saves. This is true for even the dissection of aorta or interventricular septal rupture or any free rupture. Thank you very much. I am coming up with this book. It is in edit. It is the art of healing with the heart. Almost done. It is in edit. Might be within 2 or 3 months I will release this book. Thank you very much, sir.